Matthew Holt, another TCB Quick Bite. This is Dr. Shama Rathi. She is the CEO of LunaJoy, which is a mental health company that's newer and smaller than some of the other ones we've talked about, but doing a very interesting specialized niche, which is what, Shama?
So we have a digital mental health care clinic for women through the lifespan, pregnancy, postpartum, infertility, miscarriage, perimenopause, and beyond. We provide behavioral health integration to OBGYN clinics, labor and deliveries, NICUs, and then care delivery on our platform that's in network with insurance.
All right, why do we need, given the vast amounts of capital have been thrown into different types of mental health companies and publicly traded ones, why do we need one for that particular group of women, and especially, I know you started with around the birth, sort of pre and postpartum, obviously a huge problem, but why do we need something specialized for that?
I'll say two reasons. I think pregnancy and postpartum is one of the first time in a woman's healthcare journey that there's a lot of medical touch points, but oftentimes we're not having mental health touch points. Oftentimes it's not until 6 weeks postpartum that a woman even gets asked how her mental health is doing. And so we're already setting the woman up to start her trajectory into motherhood on the wrong foot. And then the other piece of it is that, maternal mortality has been rising in the last couple of years. The United States has the highest maternal mortality of any developed nation. And so there is a big problem going on. There are unmet needs, and the care that is happening right now, the way it's being delivered, the way that it is coming across has been ineffective.
All right, so what do you actually do about this? So now, how are you getting into the market? Are you which kinds of plans are you working with? What kinds of providers are you working with? How do you get women into the system? And then, what are you doing to them that's special and different?
So from the beginning, we knew that Medicaid was going to be the way to scale. 6 out of 10 births are happening on Medicaid, and so this is a population that often gets ignored. This is a population that needs a very different type of care pathway. It's a high-touch care pathway, and so what we do really well is build out different care pathways based on different populations. And so what a woman that is going to need in a certain state on a certain payer is going to be very different based on other demographics. And so we built out care that is specialized for them, and it's meeting them depending on a lot of the needs that are going on in their lives. The other thing that we do is use data very well. So in mental health, we have a lot of data. We know oftentimes that this woman might have been on antidepressants or anti-anxiety medications, and maybe she's X times more likely to develop postpartum depression or postpartum anxiety. And so she's getting placed on a very different care pathway that she might not have had in the traditional model.
So you said two things there, right? One is accessing women when they hit the system, and the second is getting that back data. How are you doing that? Those two things are slightly different. So how are you, certainly how on the data play, how are you getting access to the data? Because that implies that you're going on looking at a bigger population of people who haven't yet come into the system or haven't yet touched you anyway. So what's the play there? How are you getting access to those things so you can be proactive?
So we provide whole population screening for OBGYN clinics, and in doing so, we're able to access the HIE and the data on the back end and calculate risk scores based on what the woman has gone through.
So that's at a clinic level. Is there any of that going on at the big plan level yet? How sophisticated are those Medicaid managed care plans? Are they ready to do that yet or not quite?
Not currently. I don't think the infrastructure really exists, but I will say based on our outcomes, because now we have data of saying like this woman is high risk, right? She should probably see a psychiatrist. This woman is low risk. She might just need to see a therapist or a coach. And based on that, the data is very consistent and the outcomes are being shown. And so I do anticipate in the near future that we'd be able to have some of those conversations.
And then what's the patient's experience now? You mentioned a coach, you mentioned psychiatrist. Obviously, how do you manage the transition between those different levels of care that's required? Number one, and then because we're in a conference about technology, what's the role? And you talked about using data and analysis. What's the role do you think of AI in the process of delivering care, yet and in the future?
So I'll answer the first one first. Is that I think a systems-based and a group collaboration is essential to getting care. I think it's really hard when a woman has to get medications here, get therapy here, get group therapy here. And so at LunaJoy, we're able to provide that under one umbrella. We have an intake center that then organizes women into different cohorts and communicates the plan in conjunction with them. So they're very aware of how that entire transition is going to happen. I will say one of the unique places that I find AI could be very helpful in our specific niche is in that specialty care. Women's health is not something that is heavily focused on in traditional psychiatry, mental health curriculums, and so I think there's a lot of AI that can be built in delivering that care.
Delivering it directly or delivering it to the psychiatrist and psychologist?
Delivering it to the psychiatrist and the psychologist.
And okay, well, we can argue later about when that becomes just a straightaway thing. All right. So you mentioned obviously we focused, that's where you started on the perimenopause, but let me rephrase that. We started talking about postpartum care, but you also mentioned that about 30% is now perimenopause. Seems to be a big topic at this conference. We just saw Halle Berry yesterday talking about it and other things. How do you find those women? Because they're kind of hidden in the shadows. So, that's not really, care for them has been bad. Let's be clear.
Yeah.
How do you find them and how do you help them?
It is an enormous crisis. Perimenopausal women have the highest suicide rate of any cohort, and unlike pregnancy and postpartum, there's not like a direct entry point into getting them. There's not a direct entry point into screening. There's no perimenopause screening that anyone is doing on a routine level, and so a lot of times we go to different specialties. We go to where women are already receiving care, so whether that's with their GI and getting colonoscopies or getting mammograms, a lot of time cancers are popping up at that time, so we go to breast and gyne clinics, but really partnering with other specialties to not only raise awareness, but also try to see how we can get in at earlier touch points to do earlier screenings for depression and anxiety.
All right, love it. So let me ask you a different question. You're a child psychiatrist, right? I think your partner is a
perinatal psychiatrist.
So that sounds different. When you go out to the market and you're competing with a lot of generalized companies, I don't know how many people are doing your niche, generalized companies, many of them not run by startup entrepreneurs. I'm not saying they don't have clinical people on board and great clinical people on their teams, but does that matter? When you lead with that card, do people think it's better, worse? What do you get?
We've definitely gotten mixed reviews. I will say that the folks that get it very fast, immediately. I think clinical leadership is very important when you're trying to create very personalized solutions. A lot of this stuff is things that have existed in healthcare for a very long time, and it's actually really interesting. People always say health tech is so saturated, but I always feel that healthcare is really broken, and so there's really this divorce, this divide that exists between the two, and I really feel that clinical leadership is going to be the one that helps bridge it.
Yeah, anyone who reads or sees my blog has frequently seen Jeff Goldsmith, who's a veteran health futurist, talk about how clinical leadership is super important and has basically been blown up by the way we've paid health care. And I'm now in the favour of saying we should give all the money to the doctors and let them figure it out. That's my basic theory. All right, talk about the money. Tell me a bit about the company, the how you're doing as a business and what money you've raised. Just give me a flavour of how big you are.
We're about 3.5 years old, and we are about 65 providers. We're across 7 states. We've raised $6.4 million.
From who?
A variety of Y Combinator is one of our biggest investors.
Oh, you went to YC and you're still alive. Well done. That's excellent. Good to hear. Fantastic. And then, give me a sense of sort of patient flow, patient volume, and how it's growing.
So we have about 65 providers, roughly around 2,500, 3,000 visits a month and growing. Majority of our referrals come from our OBGYN partners.
And how fast is your patient population growing?
About 10 to 11% month on month.
Oh, right. So if I do that math in my head, that's like more than doubling each year.
It's been fast. I think the need is enormous. The need is enormous. When we went to Medicaid, it really opened up a pipeline. And so good problem to have.
Absolutely. All right, we're talking with Dr. Shama Rathi. She is the CEO of LunaJoy. Thanks for your time.
Thank you.